Good afternoon, all. Thank you all so much for joining this afternoon. It's great to see everyone on here. And welcome to those who are joining for the first time and to those who've joined some of the previous webinars in this series. We will continue to let people join on in the next few minutes, but we will get started just so that we don't run too far behind time. So thank you again to everyone who has joined. Please note that we will be recording today's webinar so that a video can be sent around to all registrants afterwards. Now, please also keep an eye on the chat section during the webinar, where we'll be putting messages on and answering questions. We'd also like to request that everyone please check that they are on mute and that they stay on mute throughout the webinar, just to save any background noise causing distraction. Thank you for that. So today is the next episode in our series of online training webinars called Mastering Seating Assessments. Today's event will be all about the provision of seating for people with Huntington's disease. We're very pleased and excited to welcome back Alex Fisher as our guest speaker today, who has a huge amount of experience and expertise in this area. So I'm sure we're all looking forward very much to learning from Alex again. Before I hand over, I'll just have a quick look at the agenda here. So we're going to look at the various risks and health conditions that people with Huntington's disease often live with that should be looked for and considered when you are specifying seating for someone with the disease. We'll look at how to support these people with different postural and positioning solutions and much more as well. We'll talk about different chair types that are available, functionalities that you can offer, and just all the things to really enhance the lives of people with Huntington's. This will then be brought to life at the end by Ben Sterling, who is our in-house seating assessor. He'll do a bit of a demonstration to show what some of the functionalities look like, and that'll be using one of our Lento chairs. And at the end of the webinar, we'll have a live question and answer session so that we can have a bit of a group discussion. So please pop any of your questions on the chat during the webinar, and then we can address these at the end. Otherwise, you are welcome to unmute and say them out loud as well. So thank you very much for that. Lastly, I will just quickly give a brief overview of Vivid Care, who are hosting the webinar this afternoon. Some of you may have joined our webinars before, but for those of you who are joining for the first time, we've been supporting the healthcare sector for over 50 years now. We were previously known as Yorkshire Care Equipment, the name of which some may recognise. But we've now renamed ourselves to Vivid Care, which really reflects the work that we do for organisations right across the UK now, both in hospitals and in community. Our mission, as you can see there, is to enhance lives through advancing care. And our focus is on providing specialist care seating, profiling in hospital beds, moving and handling equipment such as falls prevention and patient lifting devices, and then also mobility equipment. So we really strive to enhance the quality of life for people with complex care needs, those with conditions which bring considerations that might be complex to find solutions for. We'll help you to find those solutions. And we want to support healthcare professionals and people in the community with all the resources and equipment possible. We are actually part of Core Care Group. So our sister companies include Innova Care Concepts, who specialise in hoisting and installed healthcare projects. And then there is also Aquadapt, who help with home adaptations. So without further ado, I am very pleased to hand over to Alex Fisher, to her experienced hands. Alex has spent many years working with people with Huntington's disease and in different countries too. She's actually joining us from Venezuela this afternoon. Where she's doing some volunteer work. So welcome, Alex. I'm sure everyone will be very glad to know a bit more about you and your background and experience, and we look forward to your presentation. Thank you very much.
And what's happening here is that you have a person who was impacted by Huntington's disease before they ever get a diagnosis. You see that? The parent has been diagnosed. They may be a caregiver already. They then may decide to have predictive testing, which is genetic counseling for a period of time, because it's a very important decision. Then they maybe start their own family, depending on the outcome of their predictive testing. Then their parent dies. But then, as you can see here, along the bottom, you might actually start to have symptoms of your own from about the age of about 30. Now, this is adult onset Huntington's disease. Juvenile Huntington's disease is a very different onset. The protein in all of us called Huntington becomes toxic over a certain level. And the more you have, the more toxic it is, and it's not rid from the cellular system. The more you have, the earlier the onset of the condition. So juvenile Huntington's disease have massive repeats of Huntington protein becoming toxic, and therefore the disease hits that person much earlier. Okay. But you can see that we need to deal with this referral that you're going to receive on your desk as a lifespan issue. What comes before, what comes during, what comes after. Because this is such a complicated disease, what I actually wanted to focus on for you was actually talking about people with Huntington's disease and some of the complexities that we get. So we did a webinar last month, and it was on dementia, and made some key points about important things such as pain, pressure care. We also spoke about sort of basics with regards to measurements. We also spoke about funding there. And all of those things are the same for Huntington's disease, okay? They're the same for Huntington's disease. So what I'm trying to emphasize here is, would you excuse me one moment? Hello, morning. Somebody's just bought me a cup of coffee, folks, which is really lovely. Thank you. So, okay, no worries. So an individual, we need to take an individual 24-hour systems approach to seating. But additionally, this dynamic and lifespan approach in Huntington's disease. So one of the symptoms of Huntington's disease is weight loss, and it's really, really common. So therefore, seating will need to reflect that over a period of time. So that will then impact the product that you purchase. Okay. When you get your referral, you'll usually only get a snapshot in time. So this is a really good point to emphasize. What's the intention of the referral? What is the goal? What's the problem here? Because seating serves different purposes, doesn't it? And it does for everybody. So even if you got a referral, not just for static seating, you got a referral, say, for shower seating, or you got a referral for wheelchair, you would be asking the same questions. I think that's quite important, because sometimes people get a bit muddied up about all of those things. And then what I'm going to say is often it's a complex intervention. This is a complex disease, and you'll probably, hopefully by the end of this, you'll appreciate that a little bit more, but it's a complex intervention, and it will involve more than one professional. Now, some of you on the call may be social services OTs, who maybe don't work within a multidisciplinary team, such as those in health, for example. But what I would say is that it's always worth reaching out to, obviously, say you're in a nursing home, there will be care staff that are familiar. They might not be on the shift that when you go in and do your assessment, you need to seek them out. You need to seek out family. And I would suggest probably another place to start is seek out your local Huntington's disease advisor or HD service, because chances are this person is known to them. And therefore, even though you're only getting a snapshot, you will actually then get more information that will, if you like, fill in the blanks and help you understand why this person is doing what they're doing. Again, not just about movements. Please bear that in mind. I also want you to be realistic in your seating. I want you to be open to Not perfect, but good enough. Some people might think that that's a bit controversial that I'm saying that. But I'll explain it in a little while, because it is so complicated sometimes that actually what we have to be is good enough, because we're not going to minimize risk 100%. And sometimes we might not be actually able to alter that person's posture to the extent that we might wish. So I'm going in, and I've gone into, I mean, my usual place that I go into is in the community. All right. So I'll describe it as that. So one of the first things that I'm looking at is obviously mobility. Is this person still mobilizing? What are their transfers like? What's their falls risk like? Actually, have all the basics for falls been put in place? So I work in a tertiary service, which is a regional service. So we have to liaise closely with our local colleagues in falls teams, for example, and falls teams do a terrific job. And that means that therefore all of the basics are covered. So you're just like focusing on your goal, for example. And I'm going to look at a couple of case studies about mobility in a moment, because that can prove really, really tricky. Let's look at posture. Okay, posture is very much, again, we spoke about it in the last dementia webinar, but we've got a person there who actually may have a kyphosis or lordosis. All of these things still happen to a person with Huntington's disease. It just so happens that they got Huntington's disease as well. Okay, variation in posture. Now, variation in posture goes alongside variation in chorea. Chorea is the dance-like movement that's associated with Huntington's disease. It is not consistent by any stretch. People tend to think, well, that person's moving all the time and it's all pretty much the same. No, that's not the case at all. So earlier on, a person in the chat said that they felt fatigued. I think fatigue is overlooked in Huntington's disease. So, for example, a person may be able to sit quite comfortably, even with chorea, in the morning or post-feed, for example. But later on in the afternoon, you might actually see sliding, or you might actually see an increase in chorea because they are so fatigued. So this is when I'm saying that we need to kind of look at it from more of a 24-hour perspective. Constipation is often or not, I'll see quite forceful movement coming from the abdomen and a bringing down of the legs. And that actually might be a trigger for that, might be that there's been 3 days of constipation, for example. And so you need to get very good at sort of kind of antecedent behavior consequence. What is going on with that chorea, or why is it changing? Dystonia, so we have chorea, the dance-like movements. I'm just going to give you a little sort of dance-like movement. It's like a kind of sometimes like a little twitchy bird, okay? But we also have dystonia, which is quite strong spasms. And that's quite interesting in mobility. You can have a person that is mobile, but then what they'll do is they'll have a dystonic spasm, they'll bring their leg up. And because of their balance and coordination problems, that will be the thing that possibly promotes having a fall. So dystonia should be factored in, and it can be quite powerful and it can lead to injury. So your product needs to take that into account. It needs to be very, very robust, but also quite soft. Preferred positioning. Okay, preferred positioning. This is where I'm going to say about the good enough. Okay, I'm going to ask you as part of your sort of future resource pack, to actually look at a webinar that a colleague of mine did. We did during COVID. We have produced some clinical tips which are hosted on the Huntington's Disease Association webinar. Huntington's Disease Association website. And but we did some webinar versions of the clinical tips. And Kirsty actually managed to get a photograph of a lady who still looks as though she is sprawling across the chair and not in an upright position. But her well-being is so much greater that it's therefore improved her engagement and therefore improved her function. Okay. And what this lady looks like she wants to do is she wants to diagonal sit. Diagonal sitting represents when a person is unable to communicate. It often represents an anchoring, if you like, a desire, an embodied desire to feel safe, to stop oneself moving and anchor oneself across the chair. It also happens, if many of you might have seen this, that people with HD often loop their feet over the side of a bed and are kind of holding on. And it's this kind of, okay, this is a comfortable position because this is a position in which I don't move. So just bear that in mind. You're trying to stop them moving. You're trying to get them in this kind of functional, position, which is similar to our own, but actually that person wants to be in a diagonal sitting. And I think sometimes that actually, if we want to, certainly in my experience, reduce behavioral difficulties from trying to get them into a position that we want them to get them into, we can cause other problems. Then, of course, we've got things such as continence, injury, skin integrity. This person is probably not able, they don't know, they're losing that sort of interoceptive ability to be able to self-monitor. And so therefore we need to consider that. We need to consider the mobility, and is there a toilet training program? So how is this person and their carer, caregiver, companion going to manage that using this chair? Okay. And under function, I've put communication. Okay. I think that Huntington's disease is a COM-COG communication and cognitive disorder. And therefore, instruction that you're giving actually can be, in the mid stages of the illness, very difficult for that individual. Their processing is very, very slow. The golden rule is usually about 10 seconds for a response before we jump in and we give the next instruction, which I was showing to you earlier on. You've literally lost the first instruction, and then you become frustrated. So when you're doing your assessment, it needs to be very, very quiet. It needs to be very, very slow. You need to sit and watch what's happening, and that person will show you through what they're doing, actually, which will probably then form some of the answers that you're looking for. Okay. Eating and drinking, hunger and swallow. In Huntington's disease, as I've said earlier on, weight loss is really, really common. And that's due to, for a number of reasons. It's part and parcel of the disease. It's part and parcel of actually the incredible amount of calorie and intake that they need. But we've also got it sitting alongside of swallowing difficulties and dysphagia. So we need to bear that in mind. So is our referral to support that person in eating and drinking? And therefore, what functionality does this chair need to have? Does it, for example, does that person need to be within that chair for 20 minutes, for example, post-PEG feed? We need to have that in mind. Said to you that this is a complex disorder. So the other thing here is that if we're not getting the eating and drinking right and there's hunger going on, we get increased agitation, we get increased chorea. Okay, we get increased behavioral difficulties, we get a reduction in communication. So it's all very much interlinked. It's also interlinked with cognition. Cognition here is, in Huntington's disease, as I've said, it's a dysexecutive profile. And that happens early doors. So it's not actually about short-term memory issues. That happens much later in the disorder. It's about attention and executive dysfunction. So this person might not be able to problem solve as well, because that's part of our range of problems that happens with executive dysfunction. Certainly when we're talking about risk, and risk assessment needs to be part of this. We've got a person is unable to forward think. They're unable to therefore judge risk because they can't imagine those scenarios. Then we have behavior, which again, you have to factor into your assessment. This is why you need all of that good information, because we've got impulsivity. We've got a person who we're going to look away for 5 seconds and they have whipped out of the chair. Okay. And then if their mobility is not so good and their falls risk is high, then we've actually got that problem to try and negotiate. We've got rigidity of thought. In other words, so people will say to me, I don't need a chair, I'm not using that chair, and that chair just remains unused. And that's actually because a person loses the ability to flex in their thought, but they also might not see why they need appropriate seating. We've got apathy. Apathy is a lack of goal-related behavior. So a person kind of knows what they want to do, but they're not able to carry it out. And actually, often you'll hear people going, oh, they're lazy, or I don't understand why they've not moved. And actually, it's not because they can't, they need your support to do that. So I remember when I was with Ben and Graham and we were looking at a chair, we were discussing how complex giving an instruction such as shuffling back in a chair is for a person with Huntington's disease. They can probably do it with support, but actually they can't necessarily do it themselves if they're having difficulty with apathy or rigidity of thought. And then all of these things will sometimes lead to agitation. It's a very frustrating, frightening world for a person with Huntington's disease. Environment, we have to consider storage, we have to consider dogs, we have to consider children, but we also have to consider a very wriggly person sometimes who gets their limbs trapped. So when you're looking at the seating product, make sure that you're looking at this, because I have been around folk who they've got into spaces and I'm really not too sure how they've managed to do it. So again, when we were looking at one of the products with Vivid, myself and Kirsty, that was one of the things that we were saying, that they must consider entrapment issues. So because then you've got a skinny person with skin integrity problems, skin is quite thin, maybe they're not getting enough nutrition, and then healing has not happened, and then you've got entrapment on top of that. I say about the dogs and the children purely because some of the functionality of chairs is obviously, it's the fact that some of them raise, for example, and many of you will have experienced that actually if a person is living at home with their family and they may have young children, because we are talking about younger people, we need to consider that, not just the person, but also their family. And then one of the biggies for me, certainly in the community, is who's going to maintain this chair? Who's operating the chair? What's their knowledge? What's the consistency of their practice? Again, I have families who absolutely know the ins and outs of many chairs, but then they have, for example, care staff who are, and let's face it, we're having a problem with recruiting care staff in this country, who will come in, it may be their first shift, and they don't know how to use it, and then our position is not resolved. So, or perhaps the chair is broken because perhaps they forced it. So we have to take that in mind when we're doing our assessment. Okay. So bearing in mind that we're taking a lifespan approach, bearing in mind that we are, if you like, dealing with a disease that is dynamic, this is my sort of little handy go-to about if you have a referral for a person in early stages of the condition, mid stages, and late stages. So in early stages, we have this ability to work with that person. There's still this internalized ability to adapt, and there's still motivation there, and volition, and perhaps the apathy is less. So actually you can work really well with that person at that particular point. But then as we're moving into the mid stages, we're probably wanting to consider a more maintenance approach to our seating. And rehab is still possible, but it's probably more compensatory at that point. And you're going to have to pull in a greater range of people to substitute that person's function. And then as we get into the late stages, we are looking at more sort of quality of life based issues, and consider it palliative. Huntington's disease doesn't have a cure currently. So it might be controversial to say this, but actually we should probably be considering the condition as palliative from the get-go. We have the ability to manage some symptoms, but not all. Sorry, if you didn't catch that at the very beginning, I did explain a little bit about medication. Okay. For me, mobility, it's great that a person is mobile. I don't want you to hear that it's not a great thing. It's actually, excuse me 1 minute. Sorry, okay. Sorry. If you didn't catch me at the very beginning, I'm actually in a village in Venezuela, and people are popping their head around the door because there's no electricity. So I've got the door open so that I can get some light so that you can see me. Oh, okay. Oh, they've just closed the door. Okay. You might not be able to see me now. Right. Okay. So, mobile. I think, maintaining mobility is really important for a person with HD, because the longer that you maintain mobility, the longer you can maintain cognition, the longer you can maintain function. However, it can prove problematic because as a group of professionals, we really, really want to reduce risk. Okay, we really, really want to reduce risk, but we have to balance that with positive risk. Okay, and that's quite typical in the case of somebody who's still mobile. So here we go. This is kind of like a cobbled together sort of case study of people that I work with. They're typically in the early to mid stages of the illness. Falls are increasing, usually due to poor coordination and balance. They may or may not be using equipment. Now, that does really depend on whether A, they can use equipment, because our equipment is not designed for people with Huntington's disease. It's, for example, wheeled Zimmer frames or three-wheeled walkers. You can imagine that if you've got a lot of chorea and problems with balance and coordination and multitasking, i.e. using brakes, it may be very, very difficult for you to use. So you may not be using it because of that reason, or they may not be using it because actually they don't believe they have Huntington's disease, and they're not really aware of the impact of their condition on their well-being. And you may very well encounter that. Okay, so you've got this kind of double whammy going on. Chorea may or may not be present. Transfers are heavy. They're usually really, really heavy, and so therefore quite forceful. Executive function is impaired. Apathy is increasing. And here's the other thing, proprioception. The proprioception is the ability to understand where your joints are in space. So even though I've been sitting in the dark, I know that my hands are at the end of my arms and they're folded between my legs currently. And I know that without looking. But people with Huntington's disease lose that ability, okay? The world is a very, very strange place. But also we now know that interoception is changing. And interoception is the ability to feel what's going on inside oneself. So as communication wanes, if you like, they're more reliant on how their body feels, but actually their body is not exactly telling them the right information as well. So, okay, how do we sort of take that into account with our static seating? First and foremost, we probably need because of the heavy transfers, we need a chair with 4 lockable casters. Okay, and not all products have it, so you may very well need to request that. And that is literally so it doesn't go skedaddling across the floor when the person sits heavily. We need a high back with head support, and sometimes we need it up against a wall, for example, and therefore you need to consider the environment. So you need to consider the protection of the wall. And that is because as the person is coming down heavily, their head is also coming to the back of the chair. Okay. As this person is sort of making their way towards the chair, they may not be able to judge where they should be sitting. And as they come down, they may come down and sort of almost scuff the arms. So soft arms are really important. So those chairs which have the sort of finials on the armchairs, the wooden finials, no good at all, because actually you're accidentally going to introduce further injury problems. If this person is starting to have difficulty with sort of postural stability, a banked seat or an adjustable seat that can be banked would be really, really important. And again, because we're talking about weight loss, we need adjustable width and also adjustable height. Some people like their feet on the floor because it grounds them. Remember, I talked about anchoring earlier on. And if you've got a mobile individual, actually who's impulsive, what you don't want is you don't want necessarily a foot plate in place, which they're going to come down on and then cause a further falls risk. So sometimes the better option is a removable footrest or stool with channels within it, so the person can have their foot up, and then there's the choice to have their feet down. You need to reduce the distraction in the environment, and that includes TV, radio, chatter, all kinds of stuff. And the path to the chair needs to be clear, and it needs to be in the same place. So that's taking into account perceptual difficulties, but that's also their inability to judge the risk. But it's also taking into account that actually their cognitive rigidity. Okay, so that's in their brain, even though this might be a chair that gets moved because the cleaner's moved it. Actually, sometimes what I've seen is that somebody's moved something, and that then causes that person frustration and agitation, and an episode of behavior that challenges, which is really not necessary. And then sometimes we will require this person to give, to receive prompts and guidance to reposition themselves. So remember earlier on I spoke about apathy. Well, they might be getting uncomfortable, but actually they know what they want to do, but they can't carry it out. And then they're sliding away. And we're thinking, okay, why aren't they moving? Why aren't they repositioning themselves? Because I know that they can do it. And it's actually because they require us to, if you like, guide them through that. Then what may or may not work? Okay, because we've got impulsivity, but we've also got chorea, movement sensors on the floor may or may not work. Okay, sometimes the movement sensors on the floor are better than actually the movement sensors under somebody's bottom, for example, because otherwise the chorea is constantly setting them off. I would suggest that full sensors are probably a better way to go than, for example, wearing a pendant, because that person may not in that moment actually press the pendant because they're actually not thinking forward. So i.e. I need to get up, I need to go to the toilet, who do I need to talk to? So actually what you probably want is more plugged in wall sensors. Lock and glides, I've often seen people bounce over lock and glides. If a person doesn't have a huge amount of chorea, they can work, but also if they have a vast amount of chorea, they may not work. So therefore, what we do is we're almost like funneling down to sometimes what we actually need is greater observations and or one-to-one. And that can be really controversial because funders will say, well, we're not funding one-to-one. But actually, it's down to us to demonstrate the complexity, isn't it? And to raise the risk of what might happen if this person doesn't have the greater OBS or the one-to-one. Okay, I told you that this was a complex intervention. Okay. So case study 2 is about a person transitioning. So they're transitioning from mobility to immobility. And this is actually a case that's like in the front of my head quite a lot. This is a 42-year-old man. So again, we've got a very young individual going on here. And he lives with his wife and his children, and they're 12 and 15. He's in the mid to late stages of his illness. He's minimally verbal, incontinent. Perseveration. I don't know if you've heard this, but perseveration is literally thoughts that are stuck in your head. It's not obsessive thoughts. So obsessive thoughts maybe have a more personal component. This can be something like a word. So this gentleman, when he was in clinic recently, I think he said monkey 17 times in a row. Okay. And it's a word that it comes in and it's there and it's stuck until it moves on. And it's often formed from anxiety. So sometimes medication can make a huge difference to perseveration. But anyway, this gentleman has perseveration and he calls out and he enacts routines up to 55 times in a 24-hour period. That's a huge, huge amount. He moves between the bed space and the chair, has heavy transfers, diagonal lying and sitting, goes to the floor, cannot work out how to get up. He needs support in all his ADLs and has altered diets and fluids. And because of injury, he requires the district nurses to attend daily. Okay, that's your referral on your desk. What would I do? Okay, so myself and the local OT are working this case, and we're looking at the environment. So we're looking at short-term measures and also long-term measures. For example, DFG going towards a ceiling track hoist. Because he is cognitively impaired and his wife is his lasting power of attorney, we are looking at best interest decisions. And so we have those in sort of smaller meetings and bigger meetings, depending on the decision. Can the perseveration be reduced via meds? We're trying that. We think maybe it can be reduced by about 20%, which isn't much, but gives us a little bit of wiggle room. Bed-wise, we've purchased an ultra-low entry profiling system with a cocoon open to one side because he still likes to get out of the bed space, and crash mat. And we have a dynamic care plan. Good day, bad day, what you do on a middling day. The chair, this is an interesting one because funding sort of our equipment services currently, we're sort of they're asking us quite naturally to look at sustainable solutions. So in this case, we have used what's called a recycled Sorrento type chair with a foldable foot plate. But even though that might give him a beautiful position when it has a 35-degree tilt on it, he actually still wants to diagonally lie across it, but it still gives us a greater sitting position for eating and drinking. So again, there we have that, not perfect, but good enough. We have to consider the care plan, the manual handling here. We are working from the floor to the chair to the bed constantly. So this requires us to discuss with the social worker who commissions the care and the care agency about what skills that they need to have. This all leads to the evidence for funding for what you actually need. And then with this gentleman, what we're doing is we've placed these things in play and actually we're monitoring them. We have to review them constantly. So you can see that it can be a massive piece of work, but it is possible. I guess that's my message to you. If you break it down, it is possible. Okay. Now, many of you might have noticed that I've left out people that are non-mobile. I really haven't. I am very, very conscious of the fact that they can also be very difficult to position too, particularly when they have chorea. But the foundations of practice are very, very similar. And we just need to run through those. So often people get quite nervous about hoisting people with chorea actually into a chair. But it is perfectly possible. I've only seen 2 cases in 10 years where we weren't able to hoist a person, and therefore we did have to work on the floor. Okay. But often or not, as the disease, if you like, the disease deteriorates further, we might see a crescendo of chorea, and then it comes down the other side. And because perhaps over a period of time we're working with consistent staff, there's less anxiety about being hoisted, and you can try it. Sometimes if I'm not too sure, I use a gantry hoist just to kind of work out whether it's possible or not. And then things like extensor spasm slings. I don't, for example, tend to go immediately to pelvic support. What I try and do is I try and use tilt in space mechanisms. I also try and use pommels, for example, on chairs, so that you're working in that least restrictive manner. But sometimes you do have to go for a more what looks like restraint, and I suppose technically is, but you're only using it in a timely manner. It's about what the intention is. But then you have to work out, okay, is this a deprivation of liberty? Is it not? Okay. So bringing this to a close, the additional resources that I think that you probably need to look at, please do look at the Huntington's Disease Association YouTube channel and our webinar on posture and seating. Carers training can come via the Huntington's Disease Association if you're not aware of that. And there are no-cost mechanisms and low-cost mechanisms. Then I recommend, and I'm sorry, Ben, about this, but there are 2 pages on the CareFlex page on positioning aids, belts and harnesses, which are really clear and very, very quick to read. And I really like Lauren Osborne's blog via the CareFlex on the benefits and risks of positioning aids, including sort of processing how pelvic support. And then also, I would say, see the Social Care Institute of Excellence website for the basics of the Mental Capacity Act and deprivation of liberty, particularly with regards to restraint. Because if you're not too sure, it might be something that in a case of a person with Huntington's disease that you might need to get involved in. All right, okay. I think that's where we're at. Oh no, here's my last message from a lady called Martha Nance. There's no reason to be scared, is what we're saying here, in the presence of a person with HD. Rehab therapists can foster independence, ensure a safe environment, proactively reduce the risk of falls and other mishaps. You can really improve the experience of the patient and the family confronting the disease. Thank you very much. Okay, there we go.
Thank you so much, Alex. So just a reminder to all, we have got another couple of short sections of this webinar. So stick with us for a few more minutes. But no, thank you, Alex. That was really, really helpful. You've got a huge amount of knowledge about the condition and experience.
Oh, you're welcome. And like I say, please do pass my email on to folk as needed. Often or not, it only requires 5 or 10 minute conversation.
Yeah. Absolutely. So I'll hand over to Ben now. He's got a short demonstration of an lens neuro just to show you the kind of seating. What one single seating without
Cool. Can everybody see me okay? Just a thumbs up from someone in the chat would be perfect.
I can see you.
Wonderful. That's okay. Good. Right. Well, thank you everybody for taking the time today, and thank you very much, Alex, for running through all of that. As you've all heard, there is an awful lot to consider. There's an awful lot to think about and to run through. Now, in terms of the chair I'm about to show you, this is a little bit closer to my heart. This is something I kind of began the process of engineering with the company here at Vivid. It's a privilege to be able to work for a company that are actually willing to listen and take on board and actually engineer something that is actually going to make a difference to those people that really need it. And so this is very much the finished article of what my ideas and thoughts were. I'll run through it. If you've got any questions as we go, please do feel free to just pop a question in the chat and we'll look to deal with that. But yeah, let's just get underway with it. So as Alex said, there's an awful lot of different things to consider, and there's an awful lot of different parts of the process. Okay, so with this chair, we are trying to follow the journey of the condition with the individual. So we will look to have various parts of adjustment within the chair. The main one that I was really feel is important, that was talked about a lot by Alex, is actually width adjustment within the chair. So we want to follow the person on their journey. We want to ensure that from start to finish they're supported correctly. And so with this chair, as standard, we have got width adjustment. We can start out from anywhere here, so it's around 22 inches in seat width, and then we can actually bring that seat width in, and we can actually lock it off as time goes on, as weight may be lost as a result of the condition taking hold. So we have got quite a bit of adjustment on both sides of the arms there. Now, one thing that's important about that width adjustment is we need to ensure we're able to fulfill that without, as was mentioned as well, the risk of entrapment for the patient. And so it's actually housed within a very padded and very secure cushioning around the outside of the arm of this chair, so we're not actually going to cause any injuries or any risk to the client there. Now, we have limits on the width as far as we can go here in terms of the frame of the chair, but if the patient will continue to losing weight, we have also then got our adjustable cushioning here, so we can actually, if needed, we could take some cushioning round, we could drop the lateral cushion to the base of the chair, we can actually decrease the width even further, but not actually cause too much discomfort in the process. That would still support, it would still keep them safe, but it is also, giving them it's keeping them nicely central in the chair and obviously just fitting to the dimensions of the patient. Now, the other thing we've actually done with this chair is we've got a depth adjustment capability. Now, obviously we're dealing with people with all different sizes and shapes, so the idea of this is that we could, if you've got a number of different clients that you're considering, you've got one patient that's in need of it now, and then another one comes up a bit further down the line. We can use it for this client for as long as they need. You can then adjust the depth, either bringing it forward or bringing it back, depending on the height of the person, and then you can reset it, redistribute, and away you go again. So the recyclability is there, and we've obviously assured that, again, it can follow the line of the condition for the individual, whether it's width or depth adjustment that is needed. Now, what we've also got here, and I'll be interested, Alex, to obviously just get your thoughts on this. One thing that wasn't mentioned but we have considered is quite often patients can struggle to regulate their own body temperature as well. So there's a lot of sweating that can happen. There's a lot of obviously that, coupled with the movements that we're talking about here, it can in some instances relate to shearing. You said yes, is that good?
Yeah, it's totally, yeah. Thank you for putting that in there.
That's absolutely fine. So what we've actually done on this is we've lined it with a mesh, rather than the usual result or solution for most of these chairs is Dartex. As great as it is, it does actually encourage, or can actually give people a bit more of a challenge when it comes to sweating. So this actually makes it breathable and just prevents that from at least along the backrest side of things. It just ensures that that patient is going to be in a little bit more of a comfortable state. So again, trying to avoid that agitation, which then leads to other impacts following the way the condition transpires. So we've got that padded cushioning there. As well as that, though, what it also does is it just ensures that it's taking the force of those movements as well. All those movements that we were talking about before, that were mentioned, It's good, as you mentioned, about it being robust and soft. Those are the two key words, really. We want to make sure that we're actually going to support and manage to weather the impacts and the movements that are taking place, but we don't want it to be at the cost of the client who's having to sit in the chair. You know, we don't want them to be injured. We don't want them to feel the pain and the force of what's going on. And so the padding of this chair ensures that they stay comfortable. The reinforcement at the base and the backrest of this chair ensures that they're going to be able to withstand the movements that are taking place. We've also got the lateral cushions here to ensure that when we're transferring in, that we're managing to find that good midline. Again, as Alex has said, if the client doesn't want to, if they want to adjust themselves, they're going to do it, and they're going to get to a point where they're probably comfortable. It might be diagonally lying across. As you said as well, we're not looking for perfection, but it will ensure that they're supported within the safety parameters of what the chair can fulfill. The arms themselves as well are also nicely padded, as was stipulated before. Definitely a thought we were considering, and the risk of entrapment is very much minimal. Now, in terms of the movement on the chair here, in terms of what we're wanting to achieve, oh, by the way, we do have 4 brakes casters as well. Very much important. You mentioned it, Alex. I'm glad you did, because we agree with you there. You do need to be comfortable and supportive as much as possible, and also safe with this. But on this chair itself, what we've actually got here is the tilting space function actually deepens the seat rake on the chair. So what that ensures is that they're nicely cushioned, comfortable, set back in the chair. What this is doing is it's giving a good seating posture. So we're getting that pelvis nicely back, we're giving a good position there. But it's also keeping them safe in the sense that we're not going to be slipping or falling out of the chair as a result of the movements that are taking place. So if I just demonstrate here, there's little risk or chance of me actually coming up and out of this chair now. I'm nicely supported, and I've done that without the need of the belts and other things that can be seen as a restraint that were mentioned before by Alex. You know, the idea of this is we want to maintain as much comfort as possible. We want to ensure that the client is seated correctly as best they can be, and is able to just get the best comfort and posture out of the chair without having to keep them back, force them into a position that they might not wish or like in that respect. Now, the final thing that I'll run through on here just to finish things up is, as again was mentioned, sometimes they might have a preference to keep feet on the floor. So we've got that option for this chair. You can do that quite comfortably. But if you felt they actually needed more support there along the legs, we do have a foot block that can come along the side here, clip into place. Again, we do have 4 casters braked on this as well. So you've doubled that up, you've just got the 8 casters in total. But what we can then do is we can ensure, if a client is then hoisted into place, that this is going to obviously be down in, this can be attached afterwards. It can keep the legs in a nice upright position. And I'll just demonstrate quickly. You can see there that we've got a good line of support within place. The comfort and the arms and everything, the support there, the support of the lateral cushions at the back. We can adjust the cushioning at the top. We can add extra head support if we need as well. We've got a good range, a good overall picture here of being able to support this client comfortably without any needs of extra belts, buckles, other bits of restraint here. Just a quick one on the leg block. It is a channeled leg block, as you can possibly see from the front. So we are following a nice shape of the legs. And importantly as well, we're actually holding the same line or falling in line with the end of the seat cushion as well. So there's no break in terms of where the leg finishes. We're not set up too high or too low, so that leg is getting a nice full long support from the back of the seat cushion through to the end of the foot block here that follows as well. And it just ensures that we're able to give a bit more flexibility, a bit more range to the individual in the chair. Like I say, it is a hoist friendly chair. We do have cutouts here at the side So you can get your hoist right in where we need to be, and we can get ourselves right into the back of the chair, but it also does give capability to transfer into the chair if you need to as well, if the patient is still standing. So we've tried to cover as much as we can, but as Alex has said, you've got to look at it case by case. We've got to consider the environment, we've got to consider a number of different factors and things to ensure that we're getting the best sort of solution out there for your clients. But that is the Lento Neuro in a nutshell. Appreciate you taking the time to be with us today. If you have any questions or queries on this, please do get in touch with us. If you've got people in mind that you want us to assess with, I'll gladly come out and do that as well. But yeah, we'll hand it over for questions if you have any.
Awesome. Thanks very much, Ben, as always. That was great. So that's an overview of the Lento Neuro chair, which is part of our Lento family of chairs with we've got care chairs and a few other bits as well. So we'll be happy to bring you through those separately. But we'll just move on to questions and answers now. I can see there's some great ones coming on the chat. And thank you, Alex, for starting to address those. So we'll just go through the ones which come through. So one from Nicola. Have you any particular advice on mental capacity and seating, please? I'm not sure if you've got anything to say to that, Alex.
Hi, Braden. I've already answered that in the chat.
Okay.
But what I would say is, if you think that the person that you're working with lacks understanding with regards to your seating assessment and the risks that they pose to themselves, do try and assess their capacity, of which there's plenty of guidance. Again, lots of webinars on the Huntington's Disease Association about how to do that, and then go from there. Follow the process, the Mental Capacity Act process. That sounds a bit scary, but actually will enable you to hopefully make decisions in that person's best interest. Okay, so there's a process to follow.
Brilliant, thank you. And I see you've also replied to the question here about, do you have any particular preferred supply for slings and pelvic?
If you are absolutely, with your clinical reasoning, coming to the point where you're thinking, actually, this person needs to sit out in order to be able to function, but the functionality of the chair as it is right now is actually not going to meet their needs, then you're wanting to look at pelvic harnesses, which we do use in Huntington's disease, and people tend to look at them and they're a little bit scared of them. Again, follow your process, but I would say that you need to make sure that your chair has D-rings within built into the chair, so that the pelvic harness can be fitted appropriately. I would also ask your provider of the chair to come out and show you how to do it, because what tends to happen, in my experience, is that we order pelvic harnesses, they turn up at a person's house, somebody has a go at fitting them, and they get into all sorts of pickles. And remember, this is a pelvic harness. This is a sort of a piece of kit which actually can cause injury, particularly in an intimate area. So we need to be very careful about that process. Silverlear balance slings are my go-to for the extensor spasm. And then you can work from there. If that's not going to suit, then okay, then you work with your sling provider. And social services OTs are super fab at doing that. I've seen some excellent slings, in situ slings, shower slings. Again, you want to be thinking about your in situ sling versus taking it in and out with a person with profound career. That again should be part of your reasoning. Okay.
Just quickly as well on the pelvic harnesses and belts there, I agree with you, Alex, there completely. We do have a facility to affix this onto here safely and in the correct manner, but as you can probably gather from the both of us, it's not the first port of call, and it's not something we would jump to straight away. It really has to be thought about, but we do have capability within this chair if you felt it was necessary.
Brilliant. Thank you. There is a few about the Lento Neuro, but before we do that, just do one more for you, Alex, which comes through. How do we find the Huntington's Disease Advisor in our area? It's from Haley.
This is super fab, you know. I keep going back to the Huntington's Disease Association website. Oh, look, there we go. Kerry has put them on there in the chat. Honestly, this is the most approachable charity going. And they literally have the names and emails of your local advisor. Now, bear in mind that they're not going to coordinate for you, but they will know the people who know the people who know the people in your area. Yeah.
Brilliant, thank you. So a few questions regarding Delento Neuro. So the name of the chair there, it's Delento Neuro, so that's spelled Neuro. When we send around the email later this afternoon with the recording of the webinar today and the slides, there will also be a button to click, which will bring you through to the web page for that, with more information and a little video about it, and you can get in touch as well if you would like a demonstration or assessment. Ben, a couple for you then. Are the foot blocks height adjustable, please, if you're wanting to reuse for a different client?
They aren't height adjustable, no, but within the proportions of the chair, it shouldn't be too big an issue. What you might need to do is just look at how much tilt you're putting on. Again, the length of it, the block is just the set size. Again, if you're worried about the length of that, we can also bring the depth of the chair forward, so that should hopefully help there. But height-wise, it doesn't generally change, but it shouldn't need to. It's basically the answer for it. It does have nice sort of line down, so it should hopefully fit most people. But yeah, if we were to struggle with it, we'd probably look at then customizing a foot block for a certain individual. But I haven't needed to do so far, so it might be worth checking that and having a look.
Brilliant, thank you. And then from Luciana, can you tell us what the cushion base is made of? Would it be for those at high risk of developing pressure areas? Would we have a choice of base cushion?
That's a fantastic question. I almost maybe should have already put that in there. Thank you for highlighting my misplaced or missed opportunity. Basically, within the chair, we have a full range of different options there. We can do alternating air, we can do gel, we can do medium pressure foam. The one that comes as standard is just your medium pressure relief, but majority of people would tend to go with a cool gel, which is a good high level. And within this, you just literally take the overlay off, you pop your cushion of choice in, pop it back in place, and that's as quick and easy as it is.
Brilliant. Awesome, thank you. And I've also got someone saying, can people rent these chairs? So in different circumstances, we do offer sometimes a trial of the chairs to see if it's going to be right for you, but that is dependent on a few factors. So what I would suggest is maybe get in touch with us after this webinar, and we can talk through your client and circumstances, and we can maybe look at the options for that. But we'd be really keen to help out if we can. So in terms of who our rep is for the UK, I sort of question that as well. That will also depend a little bit where you are contacting us from. So again, we will get in touch with you after this webinar and put you in touch with the right person. So there's a few really great questions there. Thank you very, very much, everyone, for those. It's really good to be able to talk it through as a group. And if you've got any more questions after the webinar, please do get in touch with us or with Alex. Alex should be happy to share your email address as well, which is great. So we can keep in touch, keep on learning from each other. And yeah, we'll keep working on enhancing care for people with Huntington's. So I'm just going to very briefly share my screen to finish off the session this afternoon. We've got a few resources on our website which might be of interest to you. One of them being this checklist for when you are carrying out seating assessments. So it's basically run through all the different important things to consider when you are running through an assessment, and you can either print this off and fill it out on paper, or you can do it digitally on your phone when you download it. So that's really to make sure that you don't forget anything when you are running through that process. On the resources section of our website, there is a lot of other helpful content as well. So ebooks about seating, justification forms and templates when you are trying to secure funding. seating prescription forms, training videos, past webinar recordings. We've got a blog on which we've got articles going up every week on various different topics. And if you go to that section, you can also access future webinars and CPD courses, which we run each month as well. So please do go and have a look there. We build it for the use of healthcare professionals like yourselves, and be free to come with your feedback as well, because we're always wanting to improve. So future webinars, episode 5 of our training course is going to be about seating bariatric patients, and we're going to be joined by another healthcare professional for that with a lot of experience. So look out for the announcement of that. You can register and get that in your diaries if it is of interest. So thank you very, very much for joining again. And thank you, Alex. Thank you, Ben. I trust that was helpful. We'll send around the recording again, as I've mentioned before. And yeah, any feedback, any questions, please do get in touch afterwards. Thank you very much.
Bye, everyone. Thank you.